So welcome everyone to today's webinar, Let's Code Together. My name's Jane Knight and I'm an instructor with the Medra MSSO. You can see me on camera, I'll give you a wave. I'm also joined by my colleague, Dr. Caroline Wilson.
Hello and welcome everyone.
Thank you, Caroline. So the first slide just explains that Medra came about in the mid-1990s. At the time, the MSSO was put in place to maintain and distribute Medra, and the activities of the MSSO are overseen by a management committee, which has representatives from both industry and the regulatory authorities across ICH regions. The next slide is a disclaimer that Medra is owned by ICH, as is the material that we will present today. We don't distribute these slides, but there is a recording, and if you quote it or use it in any way, you must acknowledge ICH as the owners. I've already explained that we'd like to make this session interactive, so please do use the questions panel to ask your questions or make comments. Sometimes we get comments and we don't all agree on the examples, particularly if they're challenging ones, but in the interest of time, we may have to agree to disagree. We cannot take requests to code specific verbatims today through the question, so don't send us your examples in the questions, but at the end there will be an opportunity for you to propose new examples for us to consider for future webinars. And I should say that today, almost all of our sessions came from one of our regular attendees who sent us a number of examples, some of which we've chosen to cover today. So this is the polling tool. The easiest way to join the voting is to scan the QR code that you see on the right-hand side with your mobile phone. But if you do wish to join, you can type in just to the URL bar, pollev.com, either on your mobile phone or on a computer, nothing else, just pollev.com, literally just that in the URL field. You will then see the screen that is shown to the right, so the middle screen there, the screen, and you enter my name, Jane Knight 855, as the username. It's completely anonymous, and by entering my name, it links you to the presentation. The QR code will be shown again, and if you get lost with it, or if you seem to lose connection, try pressing refresh or send us a question and we'll show you the code again. Here's a test for you to practice the polling. Where are you joining from today? A number of you through Europe, Egypt,
Egypt as
India.
Well. India. So bonjour. Maybe Malaysia. India, Egypt, yeah. So lots of colleagues from Europe.
Clustered today.
Bonjour.
Oh, sorry, Caroline.
Caroline.
Oh, someone's a bit further afield.
China.
China. Right, so let's move on. So this is what I was telling you about the web-based browser. If you're a regular at these sessions, you'll know that we use the browser quite a lot. Well, since we've started these sessions this year, in fact, it was December last year, we have a new web-based browser that's been released. And today we've decided we're going to use the new web-based browser for our demonstrations. So you'll find it looks slightly different. And I'm showing you on the screen where you can access the new web-based browser. You can stay with the legacy browser if you wish for your own demonstration, for your own illustration. But if you want to join using the one that we're using, this is how you do it. You go how to use on the tools on the website. Choose tools, and then on the tools page on the right hand side there's a link to open the new web-based browser, and here are the credentials that you can use if you don't have your own credentials. But if you have your own credentials, use those. It really doesn't matter to us which one you use. So coding can be challenging. Sometimes there's not an exact match. Sometimes there's more than one possible approach, as we'll see today. Even the points to consider sometimes gives options. And sometimes it's a case that we understand the term differently, especially if the terms are poor quality in their reporting. And what we do in coding is that we represent those events by a best approximation. But overall, we try never to make assumptions. We always code as reported. And as you know, we always have a little cartoon or a graphic for these sessions to illustrate the challenges of coding. This one illustrates that we should always pay attention to the spelling, as one letter can make all the difference. And you see there in the cartoon, the doctor is saying to the patient, "My, that is a typo." So you were expecting the collagen injection in your lips and the liposuction on your hips. And you can see there what's gone wrong through the misspelling or misreading of a term. A bit of a funny one there. So overall, coding is a balance between applying coding rules and using medical judgment, all the while balancing risks to the patients. As you'll see today, medical references are very important in helping us to understand the reports. And sometimes it's a case that the concept you're looking for isn't in MEDRA and you need to request a new term. So having said all of that, then let's code together. At this point, I'm going to turn my camera off so that I can concentrate and you're not distracted. So the first example is one that we carried over from February, burning sensation in her spine. What's being reported here? Is there an LLT to reflect the symptom of the burning sensation and the site in her spine? And do we actually need to capture both the site and the symptom, which is more important here? And as we'll see, the points to consider document tells us that the condition is always more important to capture if you can't capture both. So what would be the most appropriate LLT here? So let's browse MEDRA first of all. This is where I'm going to go, how to use, tools, and then on the right-hand side, open the new web-based browser. Here it is. So we had burning sensation in spine, didn't we? So let's start with burn and spine. Let's start with the exact words and see if there is anything relating to burning in spine. No. So let's have a look at burning sensation then, because I don't want to look at all the burn terms. So if I put sensation in, let's see whether the burning sensation, there's something similar relating to spine, vertebra, this kind of thing. So let's have a look. We've got burning oral sensation, ears, eye, joints. Joints is a musculoskeletal issue, so joints, but I'm not seeing one for spine. Pharynx, skin, burning sensation. We have just the LLT at the top of burning sensation. And if I look at the hierarchy of this, clicking to go up the hierarchy, I can see burning sensation is a PT. It's a feeling and sensation from paresthesia or dysesthesia, but it's very general. So burning sensation, often, so I can see there, if I want to look at the details of it, I can open details and occurrences. I can see it there that it's under general nervous system disorders and general system disorders. So let's have a look at some of the others. Burning sensation in ears goes to ear discomfort as a PT, oral as oral discomfort. So MEDRA seems to place these specific, site-specific burning sensation terms under the discomfort or burning sensation in joints. Well, spine, I suppose the closest would be a joint, goes to arthralgia. So MEDRA takes the call that a burning sensation is some kind of discomfort, or if that's not available, some sort of pain. Burning sensation in lower limb goes to burning sensation. So it is a bit inconsistent. Scalp, that will be skin. So there isn't a clear pattern. It seems that, let's try pharynx, throat irritation. So I'm seeing a few preferred terms which are irritation, a couple of discomforts. The arthralgia is the joints, goes to arthralgia, and some others go to irritation or occasionally burning sensation. So this is giving me an idea of the placement of the existing terms in MEDRA. So where would you code this one? I've given you a few options there. Is it a spinal disorder? Is it pain in spine, burning sensation in the skin, burning sensation in the joints, or burning sensation? So I see a number of you voted. It's slowing down. Let's see where your votes lie currently. Oh, real mix there. So just like we saw, there wasn't a full clear pattern in the browser because the sites differ. Joints is a different type of tissue, different situation from having burning in your eye, for example, or in your ears or on your skin. So we've got a mix here. Some of you would prioritize the condition and just code burning sensation. Others of you would follow the joints line. So it's a tricky one. So let's close the poll there and let's see what our learning points are. So before I tell you which I would go for. So let's search for terms for burning sensation at specific sites to check if any of these are appropriate. So that's our number one step. Is there a term that captures the site and the condition? Check for synonyms of the site. So we might have checked for vertebra or other ways of saying burning. Maybe look for a discomfort because we saw that some of the discomfort terms linked burning linked to discomfort. And if no terms were available, we would select the closest term for the reported symptom. And of that, I would say try to seek clarification from the reporter for a diagnosis if possible, because it is difficult to know exactly what's happening here. Maybe it's a symptom of a diagnosis and a diagnosis may now be possible. But if not, based on the location of the burning joints going to arthralgia, I would code that to pain in spine with a PT of spinal pain. Now, as we saw, there were a number of options there. It's not to say that by coding burning sensation, you would strictly be wrong, but that I would try to capture something about the symptom and the location. So do we have any questions, Caroline, so far on that one?
No, it's only Kumar who has agreed that he would also select pain in spine. Otherwise, there are no questions.
Thank you. Maybe it will come with them. Thank you, Caroline. So now the next one is transient global aphasia. What LLTs are available here for this? Can all the elements be captured? So we've got the condition of aphasia. That's what we're seeing. We can see that it's a particular type of aphasia. It's global aphasia, but we're also told that it's transient. So it's happened and it's gone away. So how should we prioritize these pieces of information for best coding? And then what would be the appropriate LLT? So as we mentioned, medical referencing is important, and Dorland's Medical Dictionary defines global aphasia as aphasia involving all the functions of spoken and written language and comprehension. So this is what global means. It means all around it's both speaking, writing, and also comprehension. And as we'll see shortly, that's some of the criteria that are used for classifying aphasia. And there's some other names for it there: central aphasia, complete aphasia, expressive receptive aphasia, or total aphasia. And mixed aphasia might be a synonym, global aphasia there, because it seems that it's all communication modalities, is that the right word, are affected. So that shows that does seem to be a pretty severe extreme type of aphasia. So that's my first thought when I see this definition. I would also go and look up a definition of aphasia itself so that I understand, is there a relationship to the transient nature of it? So we see here again that aphasia could be both communicating and understanding. And we've been told from Dorland's that global aphasia is both the actually speaking or writing and the understanding. the onset of symptoms can be rapid or progressive, doesn't mean depending on the cause, it might be a sudden injury or it might be gradual tissue degeneration. So maybe the transient nature of it gives us some clue about the cause. It tells you there are different conditions which might lead to aphasia. And it then goes on to tell us the different types based on the location and extent of brain damage. 4 types there being the anomic or amnesic form, least severe, about recall. Then there's the translation, not being able to put your thoughts into speech, translate your thoughts into speech. Then receptive aphasia, and as we've already seen, global aphasia is the most severe form that's both communication and understanding, expression and reception. And again, we see here from the National Aphasia Association, they start by asking the question, is your speech fluent and can the person understand? So this is all pointing to global aphasia. We see there highlighted is the most extensive, most severe form that we're seeing here. So let's browse MEDRA and see the placement of the terms. Let's see how this affects us. So I'm going to search for aphasia. And see, we've got 20 terms that contain the word aphasia. So I can look down here. We had a few synonyms for global aphasia, but we don't need them. There it is, global aphasia. And it actually links just to the PT of aphasia. So let's go to browser from aphasia. There it is, aphasia there is under cortical dysfunction in the neurological nervous system SOC. And I can see the LLTs underneath it. Is there something there that would indicate transient? Not underneath that aphasia, no. That's where the global aphasia is. So remember what we often say, that the PT is the medical concept. The LLTs tend to be synonyms or quasi-synonyms, generally a little bit more information, but not as much. The concept is just is represented by the PT, and here this is just aphasia. So let's have a look at the transient. I can see it actually in the list, but I could search for transient, and there it is at the bottom of the list. Transient aphasia is another LLT, but it doesn't link to aphasia itself because we've just seen it. Now this is interesting because transient aphasia has its own PT. So MEDRA, in its placement of that term, has represented that additional piece of information at the PT level. So I'm now posed the question, do we select global aphasia as an LLT that just links up to the PT of aphasia, or should we choose transient aphasia, which has a specific PT of transient aphasia? And this is where we are now in our next consideration. So there it is for you to summarize our dilemma. Which one of these are we going to prioritize? Well, let's look at the hierarchy of them. Global aphasia comes under cortical dysfunction, whereas the transient aphasia goes under transient cerebrovascular events. So this is giving us a clue, if you like, as to possibly the incidence of transient aphasia is often associated with things like TIAs or mini strokes. It's a transient cerebrovascular event because the patient regains their power of speech and understanding. So maybe we would be wrong then to code it to something like this, which looks much more serious and absolute when we know it's transient. And also the fact that the PT is more meaningful because we can capture more at the actual PT level. So which would you code? Of those, what would you do? Would you code aphasia, transient aphasia, global aphasia, or would you split code and select both? Or would you choose mixed aphasia? Let's see how you're voting. You can carry on voting. It's still open. So most of you there are going for transient aphasia. We have a clear winner. A few of you would split. But remember, in your listings, probably what you see is just the PT. So let's close the poll there in the interest of time. So what our learning points are that we would search for aphasia in MEDRA, check the hierarchy of the available terms to help us prioritize the information and guide our term selection. And I would only consider to split code if aphasia is of specific interest for your supplementary analysis at the LLT level, because it's the LLT level that the global aphasia is represented. And overall, like in the majority of you there in the poll, I would select transient aphasia. Good. Any questions on it, Carol-Ann?
No questions, just a comment from Martin that one could capture the transient nature and the global aphasia as severity indicator. So obviously he would rather split code, but otherwise there is no questions.
You could split. The reason I didn't split code was because the global is lost at the LLT level, so that's probably why. But maybe you mean, Martin, somewhere else in the case in your processing. Do you mean for your severity? Is that what you mean? I'll move on to the next one while you come back to clarify if you wish, and if anyone else has got comments they want to share. My third example in this block is increased mucus in throat. This is one of the examples we were given, as I mentioned, by one of our regular attendees. So what is being reported here? When it says increased, I tend to think, is this a test result? That's what I will always, my brain always sees that when I see increased, but I don't think it is. It's just meaning that there is more mucus in the throat. Doesn't mean there's been any test, but just the word increased always makes me think, is it a test result? Is there a synonym for throat, or is there a term for increased mucus in throat? If not, do I need to think of synonyms for it, and what would I code it to? So now you vote first of all before I lead you by giving you my thoughts. What would you code it to? Is it an ear, nose and throat examination abnormal? Is it throat secretion increased? Saliva secretion increased? Throat clearing? Nasal mucus increase? Maybe it's the nose that's running down the back of the throat. Or is it oropharyngeal mucus thickening? Right. You can choose more than one. I see a number of you voting well now. Numbers are rising quickly. Yep, seems to stabilize. Sometimes we get comments that we don't leave you long enough in the voting, but this one's quite straightforward. Oh, a far runaway winner there. Throat secretion increased. A few of you have chosen other terms. So it doesn't seem to be an examination. They haven't told us that there was an examination performed, so I probably wouldn't choose that one. They haven't told us that it's saliva secretion. The patient may be doing throat clearing, but we haven't been told that. It could be nasal mucus, but again, we don't know that. So these would all be adding information, and we haven't been told that the mucus is thick, just that there's more of it. So Dorland says that mucus is the free slime of mucous membranes composed of secretion of the glands, along with various inorganic salts, desquamated cells, and leukocytes. So mucus is a secretion, so that would help us in looking for synonyms. So if we go to browse, let's have a look. We've probably seen the, there it is. I'm not recognizing it with the new interface. It's a much clearer interface. I do like it for the new browser. Mucus increased. Is there any increase of mucus? Nasal mucus increased. Urine mucus increase. Let's just see the rhinorrhea. So yeah, as you'd expect, a runny nose. So let's have a look for secretion and throat. because we've seen that Dorland's gave us the synonyms of secretion, and there's the term that all of you are choosing there. Throat secretion increased has a PT of increased upper airway secretion. I can do a right-hand click and go to browser. Good practice to do that, although it seems like it's quite a nice, good matching term. Throat secretion increased. We've used the synonym of mucus for secretion. We've preserved the location of throat. I like that. I agree with you all on this one. So I would search for the event used in MEDRA using the reporter's words. Be clear if it is a symptom or a test result and consider synonyms. Throat secretion increased with a PT of increased upper airway secretion. 3 quite straightforward terms I think I did there. I got off quite well today with my selection there. Caroline, I'm going to hand over to you now for some more complex examples. Any comments or questions from our group today? No, Caroline, have we lost you?
So there's no comments, no questions regarding this example. Jane, just confirming that our approach or our proposal to code or select throat secretion increased.
Very good. Thank you. I'm glad we agree. Thank you. So I'll hand over to you, Caroline, for the next set.
Yes. I will share now. So here we are. Do you see my screen, Jane? Did it work?
Yes, it works fine.
Okay. So next, an Aspergillus fumigatus and a Pseudomonas aeruginosa lung infection is reported. So can we capture both pathogens and the affected site? Do we have to split code, or can we find a combination term or a more general term for the reported condition? So how to approach this verbatim? Oops. How would you code Aspergillus fumigatus and Pseudomonas aeruginosa lung infection? How would you approach it? More than one of these LLTs may be applicable here. Maybe split coding is needed. Let's see what you're going for. Not everything is seen on the slide. Here we are. Lung infection bacterial, lung infection fungal, pneumonia Aspergillus, Aspergillus fumigatus, bronchopulmonary infection, Aspergillus test positive, pneumonia Pseudomonas aeruginosa, lung infection, Pseudomonas aeruginosa test positive. What would you do with this verbatim? Lots of options. So let's see what you're going for. So the preferred ones are Aspergillus fumigatus bronchopulmonary infection and lung infection Pseudomonas. So we have a split of opinions here, as you can see. So there's no clear winner. So let's close the poll. And let's get more clarity about the reported event. So the first 2 options in the poll represented more general terms for either a bacterial or a fungal lung infection. Referencing the Dorlands again, you can see that we cannot capture the reported event with either one of these options because the reported infectious agents represent first a fungus, so the Aspergillus represents a fungus, and Pseudomonas represents a bacterium. So split coding will definitely be necessary to capture both infectious agents. Also, we should always code as specifically as possible and capture the species information as well, if possible. Both Aspergillus fumigatus and Pseudomonas aeruginosa cause severe opportunistic and nosocomial pneumonias, as you can see in these definitions here, either invasive in the case of Aspergillus or hemorrhagic and necrotic in the case of Pseudomonas aeruginosa. This clearly shows that capturing the species information is important because it conveys more information about the characteristics and the severity of the infection. And according to the meta-term selection points to consider document, splitting has also to be performed to capture the affected body site as well. Here the pneumonia, as you can see in this chapter of the document. So the preferred option is to select terms for both the microorganism-specific infection and the anatomic location, if you don't find a combination term, of course, capturing both. Alternatively, you can select a term that reflects the anatomic location or select a term that only reflects the microorganism-specific infection. So in our trainings, we always use the preferred approach that is provided by the document. So here we have some examples. The report says that a Klebsiella kidney infection occurred, and the preferred option would be to split code and capture the Klebsiella infection, to capture here the microorganism specific information, and to capture the site, the affected site, you would also assign kidney infection. And the alternative options, of course, would be kidney infection or Klebsiella infection. So in all these instances, if you decide or your organization decides to take the alternative approach or the preferred approach, this should always be documented in your in-house coding conventions, and coders should be trained accordingly so that this approach, either preferred or alternative approach, is applied consistently. Now let me switch to the browser, and I will also use the new web-based browser. Let me log in and search for first lung infection bacteria. We said this is of course available. So a vague term, this was one of the options. Here we are. Go to browser, then we can see it in the hierarchy of the primary SOC, so the infection SOC, and you can see that there's lots of bacterial infections here. So it's grouped under bacterial infections, NEC. And fungal, of course, is also available. Here we are, also with specific sites. Here it is. Go to browser, and we see the term here in the hierarchy. And we can also see that lung infection stands for pneumonia. So the lung infection is a synonym for pneumonia. So pneumonia being the medical term for lung infection. Now let's look for a lung infection or the pneumonia lung infection and the specific infectious agents that we have in our verbatim. Here we have the lung infection Aspergillus. We have the Aspergillus fumigatus bronchopulmonary infection, but bronchopulmonary infection is somehow broader than was reported in our verbatim. So it would also include the bronchi and may not be fully applicable. So let's look for pneumonia instead of lung infection and search. And here we have a pneumonia Aspergillus. So again, go to browser in the primary SOC. And here is our LLT that we could find, pneumonia Aspergillus. And we see that it's actually grouped under bronchopulmonary aspergillosis. So this is the PT. And we see that the Aspergillus fumigatus bronchopulmonary infection is also grouped under this PT. So this would be the most appropriate term that we can find for our reported event, Aspergillus fumigatus bronchopulmonary infection, because pneumonia Aspergillus is also grouped under this PT, and here with this LLT we even capture the species very specifically. So what about the Aspergillus test positive? This is of course also available. Here we are. It's under fungus identification and serology, but it's of course an investigational term. What we have in our verbatim is a diagnosis, so this would not be appropriate. And also the PTC guidance tells us that we should select an infection term, not just an investigational term. Now, what about the Pseudomonas infection? Let us search again. Lung infection Pseudomonas. Looks appropriate already. Go to browser. Let's see whether we find a more specific term to really capture the species that was reported. We know it was Pseudomonas aeruginosa. And here we have pneumonia Pseudomonas aeruginosa, perfectly capturing what has been reported in our case. And again, the lung infection Pseudomonas was the other option that we had. It's less specific. We would not capture the the species in this instance. And the test result, as already discussed, it would not be appropriate to select one of these test result terms, because what we have got in our verbatim is a diagnosis. Let me switch back. Here we are, and continue. So when coding such more complex verbatims, look into, first of all, the PTC guidance for meta term selection and your in-house coding conventions. We saw that in the case of infections at a specific site and with a specific pathogen, we should look out for a combination term. And if no such term is available, we should split code and capture both the infection at the specified site plus the infection by the specific infectious agent. We should not use an investigational term to capture the pathogen, for instance. This was a preferred option in the document, and we always use the preferred option in our trainings. So, but you are free to take the alternative approach as well. If you are not an expert in microbiology, reference medical textbooks to get a clear understanding of the type of microorganism that you are looking at. And if no exact match for the reported event can be found, select a more general term, like in our example, the LLT Aspergillus fumigatus bronchopulmonary infection, making sure that the hierarchy of the respective LLT accurately reflects what has been reported. So here we have found two suitable combination terms for coding the reported condition, and we would split code to capture the affected body site and both pathogens by assigning LLT Aspergillus fumigatus bronchopulmonary infection and LLT pneumonia Pseudomonas aeruginosa. Any questions or comments, Jane?
Not so far, Caroline. No.
Okay.
No, that's a nice example of showing how you do gain more information by splitting. We had some questions on the aphasia, whether to split or not, and what could be gained. So
yeah,
this is a good example to follow that. Thank you.
Yeah, it's really important to capture everything. So the affected body site plus the infectious agent, because this verbatim really reflects two separate infections of the lung.
Yes.
And of course, we saw in the Dorland's definitions that both lung infections are really severe by these infectious agents. And so a combination of those is really life-threatening for the patient.
Oh,
So
yeah, that almost, thank you, Caroline. Thank you.
So here, our next patient suffered a contusion, and the affected site is further specified as left arcus zygomaticus and the right occiput. So do we understand what happened here? Is this a single event or at one site? And what type of tissue is affected? Let's consult the Dorlins first to better understand the reported event. The underlying event is a contusion at two different sites, the arcus and the occiput. A contusion or bruise is defined as an injury of a part without a break in the skin and with a subcutaneous hemorrhage, so it's a bleeding event. And the term occiput describes the back part of the head. Other references, like the Merriam-Webster or the Tabor's Medical Dictionary, explain that the occiput is the back part of the head or skull, so skull being a bony structure. And finally, the arcus zygomaticus is formed by the articulation of a process of the zygomatic bone of the skull and a process of the temporal bone of the skull. So these images better explain what is meant by that. Here we have the processus temporalis of the zygomatic bone, yellow one here, that's the processus temporalis connecting to the temporal bone that we see here. And the temporal bone has a processus zygomaticum connecting it to the zygomatic bone. So this structure here represents the zygomatic arch. And here also an image of the skull showing the posterior part of the skull, and that is formed by the back part of the os parietale, parietal bone, and the occipital bone. Here it is. Now, having heard that, how would you code contusion, arcus, zygomaticus left, and occiput right? Would you just assign contusion, capturing the underlying event? Would you consider this to be a bone contusion? Would you select skull trauma or craniofacial injury or bruising of face, bruise of head, craniocerebral injury, or would you seek clarification? What would you do? Quite a complex report. And as Jane mentioned, we have received them from an attendee, so it's real life cases. Let's see what you're going for. Oh, split of opinion. Most of you are going for bone contusion. Some for contusion, craniofacial injury, bruise of head. So split of opinions here. Let me close the poll and again switch to the browser. Here we are. So contusion, of course, is available in MedRA. Here we are. Let me see. Here we are. Direct match. Go to browser. Primary socket injury, poisoning, and procedural complication. Let's look into the LLTs that are grouped under this PT, and we see there is an LLT, of course, identical to the PT, and then we see contusion, lots of contusions, upper arm, wrist, limb, soft tissue bruising, forearm, breast, back. So where's our head? Contusion. Let's look at the others that do not contain contusion but bruise. Here we have our bruising of head. We had this one, so it's also grouped under contusion. And we have the bruising of face. So this would represent the zygomatic part, bruising of face, and this would be the bruise of head would represent the back of the head part, so the sites that were reported. Craniocerebral injury here we have it. If I go to the browser again, you see that it's grouped under cerebral injuries, but this would be an assumption. In our case, no cerebral injury was reported. It was just a contusion, and then the sites were reported. And bone contusion, of course, is also available. And you see that it has its own PT, non-site specific injury. So there is no one that would represent the skull, for instance, the skull contusion that would have been another option, but it's not available in MEDRA. So it would only be bone contusion, and you see it has a separate PT. Well, the arcus zygomaticus is a bony structure. We saw that. But we don't know whether our verbatim describes a contusion of the arcus zygomaticus and occiput or on the arcus zygomaticus and occiput. So how to best approach our verbatim now? Let me switch back here. Based on the MEDRA term selection points to consider document, the specific event reported should have priority when coding. So we would definitely capture the contusion, the bruising. And if an event has occurred at multiple body sites and all corresponding LLTs linked to the same PT, then we should select a term that most accurately reflects the event. As you can see in these examples here, a skin rash on face and neck. There is no skin rash on face or skin rash on neck. There is a rash on face and neck rash. But here we have a skin rash, so we select skin rash in order to capture as much information as we can, and this is grouped under rash. Edema of hands and feet, we would go to edema of extremities. Edema hands and edematous feet both link to edema peripheral, and edema of extremities most accurately, most specifically reflects the single reported term. So we would not directly code to edema peripheral because there is another LLT that better captures the reported information. So first of all, we would clarify the affected body sites when not familiar with the reported anatomical terms. We would apply the guidance of the MTS PTC when coding a specific event occurring at multiple body sites. But here we are not clear about the affected site because it isn't clear whether a contusion of the left arcus zygomaticus and the right occiput occurred, so a bone contusion, or rather a contusion on the arcus and the occiput. And here's our final suggestion. We would query to get more precise information about the affected tissue, whether this reported event relates to a superficial contusion on the head or a bone contusion. And a bone contusion is quite a severe event. So it's a bleeding event, and it really needs medical attention, so medical treatment. So we would query, but if we don't get more information, if we don't get more information about what actually occurred, we would propose to code to bruise of head, a more general vague term under PT contusion. And we saw in the browser that bruise of face is grouped under the same PT, and with bruise of head, both affected sites are captured with a more general term, bruise of head.
Mhm.
So are there any questions? Most of you, when we
No,
first discussed this verbatim, Jane and I, we also went for bone contusion, and then we realized that it's not fully clear based on the verbatim whether really the bone is affected or whether it's on the bone, because this part of the face is really very is often injured, and often you will have a bruise or so if you have like a physical assault or anything. Then you would have a contusion on the arcus zygomaticus, and with a fall you may have a contusion on the occiput, but not actually in a contusion of the occipital bone. Any questions, comments?
No questions so far, Carol Ann. One of our attendees is going more general and suggesting a skull trauma, but I was just typing in. I think we try to be more specific and capture the actual injury itself in some way,
Yeah.
so either bruise or
So
contusion.
skull trauma could also be a fracture, for instance. So as I
Yes.
said before, we should capture the underlying event. That has the first priority, and this is the contusion in this instance. With
Yes.
trauma, you would be more general. Could be a
Yeah.
fracture.
No other comments. So earlier on, one of our group was asking, why would you include a skin condition in your poll? But you've just covered that by saying that we don't know if it could be the skin over the bones that is
Yeah,
affected. But
yeah,
as you say, Caroline, we've wavered on this as well ourselves, didn't we, when we discussed it? But I
yes.
think this is the best option at the end.
So
Thank
next
you.
one. With the next verbatim, a degeneration of the joints of the spine is reported. So is this verbatim now clear and non-ambiguous, or is it too vague? Can we find other terms representing joint degeneration for other sites? And what would be the most appropriate LLT or LLTs also capturing the affected body site, so the spine in this instance? When looking again into the Dorlins, we learn that the medical term for degenerative joint disease is osteoarthritis. And there are other synonyms like degenerative arthritis, hypertrophic arthritis. And the degenerative spinal changes due to osteoarthritis are called spondylosis. So this would be the medical term for these degenerative spinal changes due to osteoarthritis. Again, let me switch to the browser and search for degenerate and spine, or joint first. Keep it more general. Typo. I'm not good in typing, not at all. So here we have the degenerative joint disease. And if I go again to the browser, I will see this LLT and it's grouped under osteoarthritis. So this is what we saw in the Dorlins as well. So now looking at the LLTs underneath, you could look out for something that would reflect spine osteoarthritis or degenerative disease, but we only see hip, hand, hips, knee, cushioning back, shoulders, generalized osteoarthrosis, another synonym, very specific ones, not involving leg, primary, thumb, varus, valgus, wrist. So nothing that would reflect the spine. So then if you have such a finding, then it's worthwhile to look at the siblings under the same HLT in order to see whether the spinal osteoarthritis is represented in MedDRA with a separate PT. So here we don't have anything that reflects the spine on the top, and here we have the vertebral osteophyte, but here we have the spinal osteoarthritis. Here it is. And under this PT, we find degenerative spine disease, which is closest to the wording of our verbatim. And it's grouped under spinal osteoarthritis, reflecting the degenerative joint disease of spondylosis. We also see the spondylosis here, the spondylosis of the spine, the medical concept that was reported. So search for joint and the word stem degenerate to capture both degenerative and degeneration terms. Look for synonyms and medical terms for the condition to broaden your search. And when you have found the medical concept, search for terms that would capture the affected body side, here the spine. Always select the LLT that is closest to the wording in the verbatim, but make sure that the reported medical concept is accurately reflected in the MEDRA hierarchy. And with this, we propose to code to LLT degenerative spine disease under PT spinal osteoarthritis. Any questions?
No questions on that one, Caroline.
Then I hand over to you again.
Thank you. Bear with me. Good, thank you very much, Caroline. So here our next one is dry spots on the skin, arms and back. Well, so here we are, spots again. So I'm sure a number of you long-term coders will know the challenges with spots and what we see there. So dry spots on the skin. What's being reported here? What does spots actually mean here? Are these dry patches? When they say spots, do they mean patches? Or do they mean that it's spots like a rash, which is dry? So can we make that call from, can we make that understanding here from what's been reported, arms and back? How would you code this one? So before I say any more, is it dry skin, skin blotches, spotlight rash, macular rash, or a dry rash? Yeah, I see quite a few of you voted there so far. Let's see where your thoughts lie. Dry skin seems to be very popular, closely followed by dry rash. Oh, and some of you are changing your mind. Those of you who are into blotches and spotlight rash, it's a tricky one. This is a tricky one. It looks like such a simple term on paper, but when you start actually thinking, well, what does this mean? It's a tricky one. So we started by looking at the actual medical definition for a spot. A spot is a circumscribed area distinguished by its colour, such as on the skin. See also dot, macule, and patch. So macule is a discolored skin lesion that is not elevated above the surface, and it will see also again patch, spot, and macula. So a spot seems to be something on the skin. It's a macule, a patch, and then we can look in MEDRA using some of these synonyms. So let's do that now. So I'm going to look up for spots, macule, it said. So let's look up dry spot first. Let's start with the exact wording. Nothing with dry spot. So let's look up spots. See what we get with spots. So we have 16 terms that contain the word spots. Spots. How about spot in the singular? A spot. Lots of very specific spots here. Red spotty rash is an macula again. So MEDRA's using that Dorland's definition of a spot being a macule. So the red spotty, erythromacular, spot-like rash, that was one I gave you in the poll, again rash macula. So Medra's taking spot as meaning macule. I thought we had just a spots, age spot, black spot. I'm not seeing a general macule. Let's look up macule. I won't do the whole because it will capture macula. 160 terms contain it. Lots more information here about the site. Macula, that's the back. We've also got the eye problems now. The macula meaning back of the eye. So that's a hard one. Rash macula is a rash macula, as we'd expect. Maculopapula. Papula means it's raised. Macula means it's just a circumscribed area. Macular rash, red macule rash. Rash macula. Spots. So let's go and look in the browser at other LLTs under that rash macula. We haven't looked at blotches and patches yet, but let's see where we are. We're under rashes and eruptions. Spots, rash macula. Under rash we've got as well. Rash, we've just got generalized rash, just general rash there. Patchy rash. What do we have under rash? We have a dry rash at the top. That's one we gave you as well in the voting, a dry rash. So it's a case of what are we going to prioritize here? What are we going to look for? Under rash macula, we've got blotchy rash, rash macula, skin blotches. So it seems like blotches or patches are treated as macules. That fits with the Dorland's definition. And macular rash, when you have multiple macules, it seems to be put under a rash, patchy rash, and not raised, remember, just patches. And we want dryness as well. So we've seen we can do the dryness. If we use rash, we can do dry rash. So let's just check with our patches and blotches that there's nothing else. Patches, we saw the patches, blotches, rashes terms there. Blotch. We got blotchy rash, skin blotches, which goes to rash macula. That's what we just saw. All the blotches goes to rash macula. Red blotches, skin blotches. So blotches are taken as being a rash. And what's our verbatim again? Let's just go back and check our verbatim. Dry spots on the skin. So they're not saying blotches, but it's spot could either mean a rash or it could mean an area. So again, it's a circumscribed area. So from that, I think the learning point is to really clearly understand the intended meaning of the word spot and what spots are and how Medra classifies spots. So search for spots in the browser. Also macule or macules or blotches, and that's what you've just seen us do. It's the browser seems to have guided us towards the rash area. So now it's a case of, do we go for macular rash or do we look for the dry rash? Consider the placement of the available terms. Distinguish between rash and patches if you think there is some kind of distinction, or if you know the type of rash, then you can look for a more specific term there. Look for a suitable term to capture both dryness and spots. And here, if we take the worst case scenario, I would say, well, I'll have to select a rash term because I might look at that verbatim and think that they're just pointing to dry areas, almost like a localized dryness, dry spots, because do they mean dry areas? Are they saying localized dryness? But they could be saying it's a spotty rash. So worst case scenario, to take a conservative approach, then I would say, okay, let's code it as a rash. But Caroline and I did have this discussion about, are we adding information by coding it as a rash if they just mean it's localized dryness? But we can't know that without really speaking to the reporter and seeing the patient. We can't know that. So we go with what is reported. The word spots is used. Medra takes spots as being a macular rash, so we've chosen dry rash to capture both the dryness and the spots rather than just coding a macular rash. So, do we have any questions on that one or comments, Caroline, on how anyone else would approach that term?
We have quite a silent audience today. No
Very
comments, no questions.
They're
All very
interesting
clear
group.
with our explanations. I don't know.
I don't know either. They were an interesting group of terms that we were given. We were given this set of terms proposed to cover, and on first look, they look like they're quite straightforward compared to some of the terms we've done in the past. Although your zygomatic one was tricky, but when you actually come to dive into them, there is an element of ambiguity in a few of the examples.
Yeah. So there's one question now. Where does dry skin goes to? So dry
Oh,
skin, the term dry skin in Medra.
yes, let's do that search then to do it together. Dry skin. Dry skin is an LLT and it has a PT of dry skin and it's in the skin sock as you'd expect, uniaxial up through the dermal and epidermal conditions not elsewhere classified. I can show you it within the go to browser, right hand click, go to browser, and there it is down here, dry skin, and it has underneath it dry scalp, dry skin on the face, hot and dry skin, xerosis, a synonym there for dryness, and there's a few rough and dry and scaly and dry skin there. So not rashes with the dry skin. If we'd done that, we would have captured it as a skin condition, but we wouldn't have captured the rash. And because of the word spots, I didn't want to exclude the fact that it may be that it is referring to a rash, dry spots, because that's what's actually reported.
Yeah, it's not the whole skin that is affected. That's why we thought that we should capture the blotches as well, the spots, because we have some comments here that rash would be an interpretation, but based on what we see in Medra, that the blotchy LLT blotchy is really grouped under a rash term, we thought that dry rash is the best approximation to our verbatim.
We did consider that. Were we adding information by coding a rash? But because of the word spots, spots could mean areas, or it could mean that there are circumscribed areas that are flat, not raised, distinguished by colour. That's the Dorland's definition. So we did go, as you say, Caroline, because it's localized, and we went with the Dorland's definition. Worst case scenario, we went for the rash, but we did have that same discussion ourselves.
Yeah, Martin comments and says, I would possibly try to follow up because dry skin area may be symptoms of serious conditions like psoriasis, for instance.
Yes, possibly plaque type roughness of the. It could be localized dryness. We had this exact discussion because I was the one saying, wasn't I, Caroline, that well, I'm not sure that there's a rash there, because I would say spots. I'd think of areas, dry spots on the skin. But yeah, that's what we went for, worst case scenario, but we do recognize that there is some ambiguity there. But that was our rationale based on the Dorland's definition and the placement of the terms in Medra. So I've got another spot term for you now. Any more comments?
Yes, we have.
More comments. Another example. Now our other example is eyes, white spots. So I'm not going to say too much because I'll lead you. Where are these spots? Is it a visual problem? Is the patient seeing spots before their eyes? Is it an examination result? And what would be the most appropriate LLT? So remember, these are all real terms that one of our attendees sent us. This is another one from the set we were sent. What do you understand? So now I'm giving you a choice. These are not Medra terms. I'm asking you what you think is happening to the patient. Is it white patches in their vision? Is it flashes reported by the patient, maybe significant for retinal detachment or this kind of flashes? Is it floaters that the patient may report as being spots, floaters or debris in their vision? Is it an examination that it's spots on the retina, spots actually on the eyeball, on the globe of the eye itself, or is it spots in the lens? What do you understand? What do we even think is happening to this patient? If you had to make a guess, what would you think? And I think it probably would be a guess. Or if one of your friends said to you, "Oh, I've got white spots in my eyes, white spots." We don't know if it's in the eyes or on the eyes, or a few of you have making a choice. Let's see what's the most visible on the eye. Now that's interesting. Visible on the eye itself. White patches is quite popular in the vision. Floaters maybe, spots on the retina maybe. So let's see then, but the winner in the voting is visible on the eye. So I've just picked together a few of these possibles to show you the ambiguity. So it could be floaters. Floaters is defined by Dorlands as spots before the eyes. So just to show, I think this one can't be discounted. It could be, this is due to deposits in the vitreous of the eyes, and we see that in the picture on the left. And on the right side, you see how the patient's vision is affected by these spots or strands of debris. So it could be that these are appearing there as being white, either on examination or that the patient reports them as being like that. So that can't be discounted. From a website here called Optical Coherence Tomography scans, they define retinal exudates, and this is how this looks on fundoscopy. So lipid residues that leak from damaged capillaries, and this is seen in diabetic retinopathy, but you see there on the scan they appear white in the light. Retinal drusen, another example of white dots on examination. This is lipids and proteins, a sign of age-related macular degeneration. So we can't make any of these assumptions, but we can't rule out any of these things. We see there the white dots. It could be a cataract, type of cataract, which visible again from the outside of the eye, white dots. Here we see one called a snowflake cataract, which appears as white dots organized like a snowflake in the actual lens itself as a type of cataract, or an actual white spot on the eye, a raised lump. We see here a pinguecula, as meaning somewhat fatty, a yellowish spot of proliferation on the conjunctiva. So here, it could be any of these. We can't rule out any of these, and I've just selected a few. So without knowing the site of the problem, it's very hard for us to make any assumption. Even if we knew perhaps the part of the body affected, without a diagnosis, we would still be adding information or making a judgment. So here we would use MEDRA, use medical references to understand what the report may mean, consider all the options to ensure that when we code there's no ambiguity. We would look for other information in the case potentially to help inform a query asking for clarification, but we would need to seek clarification, and we can't make any assumption there other than if there's no information available, we have to code it to eye disorder. Okay, any questions, Carol Ann?
No, Martin has confirmed our approach to just code to eye disorder, because it's an ambiguous term, and if no further information is obtained, then we have to keep it vague.
Good. Right, I'll hand over to you, Carol Ann. You've got two left, and we may not get through them both, but I'll hand it back to you.
Yep, let me. So here I am again.
Perfect.
In our next example, an infection of the cuticles of both thumbs is reported. So do we know whether the medical term cuticle relates to the skin, the nail, or the finger, here the thumbs? Are there synonyms or medical terms we could use for our search in the browser to find an appropriate LLT or LLTs? So what can we do with this? How would you approach this verbatim? Would you consider an infection of the cuticles of both thumbs an infected finger? Would you select bacterial nail infection, unspecified local infection of skin and subcutaneous tissue, perionychitis, periangual infection, or panaricium? What would you select for the reported verbatim? So very specific local infection at the thumbs. Let's see what you're going for. Most of you are going for infected finger, but others also for an unspecified local infection of skin and subcutaneous tissue, periangual infection. But we have everything in your proposal. But the preferred one seems to be infected finger. So let's close the poll. Thank you for joining again. And if you look at your nails, there is a half moon shape at the base of each nail. So this is called the lunula. And the cuticles are directly below it. So the cuticles are at the intersection between the skin and the nail. And you can see it here. Here's the cuticle, here's the nail, and this is the skin. So the cuticle is above this nail, the rim of the nail. And it's also called eponychium. And in Dorlans we can find synonyms for cuticle. Among those, eponychium, but also perionychium. And the medical term eponychium is defined in Dorlans as the narrow band of epidermis that extends from the nail wall onto the nail surface, sealing this space in order to prevent infections. But of course, if you have an injury in this area, then infectious agents may penetrate this space and cause an infection. So let me again switch to the browser and look for infected finger. Of course, this is a very broad term, could relate to any. Go to browser. Here we are, infected finger. It's grouped under localized infection. So because the infected finger, it's a localized infection, but we don't know. It could be the nail, it could be any part of the finger. So that's why this seems to be too vague. Bacterial nail infection is available. Here we are. Here it is. But we don't know whether the nail was infected. Based on what we saw before, it's rather the skin, small piece or part of the skin surrounding the nail, the wall, that skin wall that is surrounding the nail. It's not the nail itself that is infected. The unspecified local infection term here is unspecified local infection of skin and subcutaneous tissue is quite vague. Let's see what it's grouped under skin infection. Not bad. Yeah, we don't know. It's a local infection. We know it's an infection of the skin. Also subcutaneous tissue could be affected depending on the severity of the infection. And it's grouped under skin infection. But with this, we completely lose the affected body side, so that it's really the thumb and the surroundings, the skin surrounding the nail. So let's look at We had periungual, for instance. Here is the periungual infection, and go to the browser. And we see that this periungual infection is grouped under the PT paronchia. So other terms are here as well, and also perionychitis. So perionychitis is exactly what we saw in the Dorlins. So an infection of this small wall of skin that is surrounding the nail. So this seems to be the best approximation. It's not covering the cuticle. There's nothing that refers to the cuticle here. It refers to the whole skin wall that is surrounding the nail, but it's the most specific term that we can find, perionychitis. So it's grouped under paronychia, and if I look at the hierarchy here, it's considered an infection. So, and it's considered classified as bacterial infection. So it's exactly reflecting what has been reported in our case, because the verbatim said infection, cuticles, both thumbs. So we have found a term in LLT that really captures, more vaguely, but captures this affected body site. It's grouped under paronchia, and this is correct because it's classified in the MEDRA hierarchy as an infection. Let me switch back. So let's make sure again that the paronychia really represents what has been reported. It is an inflammation of the folds of tissue surrounding the nail. So that's what I've already told you. That is also called perionychia. So perionychia, it's a tongue breaker, really. I try to spell it or pronounce it without getting into trouble, but it's really difficult. Perionychia. So here it is. So the cuticle is only a part of the skin fold, so it's a more general term, but it includes the cuticle, so our reported condition is accurately reflected by this LLT. And although it's only reflecting perionychitis, the itis just reflects an inflammatory condition, but we saw when looking into the browser that the MEDRA hierarchy really classifies this condition as an infection. So when getting such a report, first get clarity about the exact localization of the infection that is reported. For this, consult medical textbooks, dictionaries to find medical terms for the infection of the cuticles. If you don't find a direct match, explore MEDRA using word stems to find a term that accurately represents the concept, maybe with the best approximation as we saw, and make sure that the MEDRA hierarchy represents the condition as an infection, because this was reported. And with this, we would propose to code to perionychitis under paronychia, under this PT, paronychia. And we saw that this is classified as a bacterial infection. So although it's not really contained in the LLT name, because itis just describes an inflammatory condition, nor is it reflected in the PT name, but it is classified as bacterial infection in the MEDRA hierarchy. So our verbatim is perfectly coded with this LLT, perionychitis.
So we did have a comment, Carol Ann. Yeah. We did have a comment. The other term, you good, well done there. Congratulations on your pronunciation. Is my comment on this.
Terrible.
Panoricium. Is that how you say? Yes, how you said that one. Panoricium.
Panoricium, yes.
It's one of the other LLTs under the PT of Paronychia. So we just had a comment there that that might have been an alternative, because there are a number of terms under that same PT, aren't there?
They are, yeah, but I looked into it. It's a more severe condition. So if you really only would like to cover the skin wall that is surrounding the nail, and this is what is reported here with the cuticles, then this perionychitis is the most specific term that you can find. Panoricium is a more severe, so it's spreading around
Oh,
the nail,
thank you,
and
Caroline.
may even affect the subcutaneous space of the finger.
Thank you. Sorry if you may have already said that and I missed it. Thank you,
No,
Caroline. Well, have we got time to do the last one?
I think it's 11:26. We should maybe, based on what we discussed before, because we had these questions about the Medra learning system, so the self learning in that we offer now. Maybe first,
Okay.
yeah.
Well, so what we have for you now, we have I think I'm sharing, is that correct?
Yes,
We
you are.
we we've got a survey for you to tell you, to ask you what you thought of the session today. And this is where, if you have some examples of topics or verbatims that you'd like us to cover, then you can put them in the survey. But please do remember that we have to have examples which are of general interest and that we can draw learning points from. Though it's not an opportunity for you to send us your very hard terms that is very specific to your drug or your precise area of work. We can only code terms that do follow the coding principles and where there are Medra options available generally. So that is what I would say. And our next session isn't until September. So we've got the summer in between. So if you want to send us examples now, we can look into them, or topics that you feel we haven't covered. We have covered a lot of topics in these sessions. They're all recorded and you can find them on our YouTube channel. There's a playlist. You can look back, and we've been doing it now for coming up for 5 years. So you can really look and see back. All of them are there. They haven't been removed. Sometimes newer terms may have been added to Medra for the examples. So take them as the time that Medra was, what was available at the time when we recorded them. And if you want to see what verbatims are included, you can see in the description of the session what's been included. You can also see on our website, we have an index. I'm not sure the index is fully up to date at the moment, but we're going to look into that when we get some downtime over the summer. So that's the YouTube playlist. In our survey for a webinar that Caroline gave last week, we also were asked about the what training materials we produce for ongoing coding. We regard the Let's Code as one of the more advanced coding sessions that we offer because they're challenging and they're real life examples. But we were asked, could we provide other material, maybe looking at specific challenging areas? So this prompted us to think, well, maybe we'll show you our website and we'll show you that we do have now a Medra LMS system, learning management system, under training. You can go to the training materials, and this is where you'll see there's the Let's Code under coding. This is where you'll see there's the Let's Code information with the index and the link to the website for the most recent sessions. But also if we go to training, go back to training offerings, is it there? No, where is it? We have the schedule. No, it's somewhere here, isn't it, Caroline? Training, instructional videos, that's where it is.
Yes.
Oh my goodness, I had a mental block. Instructional videos. We've been working on a number of videos. The top section are how you actually use Medra. So these are the practical, how you use the Medra tools that we offer you. But underneath it, there are a number of videos. Now, these videos are focused on individual challenging areas. So there's within the module common coding topics, There are units on how to code diagnosis, signs and symptoms, how to code combination reports, for example, investigations or indications. And then we've got special situations with medication errors based on Carol Ann's webinar material, drug interactions, things like this, product-related topics, pregnancy, and then a quiz at the end. So having shown you them there, you can see the note at the top says these are going to be removed. So what we've done is we've put them all, and I'm now looking on the right-hand side, we've put them all in a Medra LMS, Learning Management System. So there's an orientation video there. There's the link with the green icon, and there's a flyer. So you can go straight there to this Medra Learning Management System, create yourself an account. You only have to do creating the account once, and then it will remember you. So don't be put off if you think it's a bit of a complex process to create your account. It's worth doing because you only need to do it once. Then you can just log in straight away. So all the information on how to use the LMS is in the LMS guide, either within this platform itself or on our website where I just showed you. So that's in relation to anyone who's asking for other materials we have that help to cover challenging areas. Anything you'd like to add, Carol Ann, on that one? And you've got a webinar next week on advanced coding, haven't you?
Yes.
No.
Yes. No, nothing to add other than really many different topics are covered by the LMS system so far.
Yes. And you've got the opportunity to give us feedback in the survey. You'll have the standard survey as well as the quick survey that you're filling in now. You'll have the standard survey after the session if you have other thoughts that occur to you. And here are our social media channels. You're welcome to email us through the help desk. Carol Ann and I will pick up your emails there if you want to send us suggestions. And there are also some WhatsApp groups. If you have a smartphone, you can join there, a WeChat group in China and a WhatsApp group across Europe and other parts of the world in local speaking groups, if that's of help to you. So that's all available from the contact page, top right hand side of our homepage. So that's everything we wanted to say to you today. We've got one term that we will come back to in September when we see you again. Otherwise, just thank you all for your attention, for your active participation. Lovely to see you again if you're a regular. I hope you have a very good summer, and we will see you in the summer here in our hemisphere, and we will see you in September. And thank you, Carol Ann, for your collaboration as always.
Thank you, Jane, and thank you to everybody. Have a nice summer, have nice vacations, and hope to see you in September.
Bye-bye for now, everyone. Bye-bye.
Bye-bye.